Before we dive into direct-acting vasodilators, let's take a closer look at another cornerstone of cardiovascular pharmacology, diuretics. These medications play a vital role in managing high blood pressure heart failure edema by helping the body get rid of excess fluid and sodium. How do diuretics work? They increase urine production by acting on different parts of the kidneys. By promoting fluid loss, they lower blood volume, which decreases blood pressure and reduces the workload on the heart. There are several types of diuretics: thiazide diuretics, hydrochlorothiazide, loop diuretics, furosemide, potassium-sparing spironolactone. Loop diuretics are the go-to for heart failure severe edema. While diuretics are highly effective, they are not without side effects. Electrolyte imbalances, low potassium common with thiazide and loop diuretics, high potassium seen with potassium-sparing diuretics, dehydration, dizziness, increased urination. Nurses should educate patients to monitor for signs of dehydration, muscle cramps, irregular heartbeat. Diuretics are generally well tolerated, but they're not suitable for everyone. Contraindications include severe kidney dysfunction, electrolyte disturbances. Always assess kidney function and electrolyte levels before and during therapy. Understanding the different types of diuretics, their mechanisms, and their clinical uses will help you manage cardiovascular conditions more effectively and ace those NCLEX questions. Let's shift our focus to another important class of cardiovascular drugs, direct-acting vasodilators. These medications work by directly relaxing the smooth muscle in blood vessel walls, causing the vessels to widen or dilate. This vasodilation leads to a rapid decrease in blood pressure, making these drugs especially useful in situations where quick blood pressure control is needed. One classic example is hydralazine. It's often used in cases of severe hypertension, including hypertensive emergencies, and in certain cases during pregnancy. Another example is minoxidil, sometimes reserved for patients with resistant hypertension, meaning their blood pressure is difficult to control with other medications. While direct-acting vasodilators are effective, they come with their own set of side effects. Because they cause blood vessels to suddenly relax, patients may experience headaches, flushing, a rapid heartbeat, known as reflex tachycardia. Fluid retention is also common, so these drugs are often prescribed alongside diuretics and beta blockers to counteract these effects. Clinically, it's important to monitor patients closely for sudden drops in blood pressure and to educate them about the potential for dizziness or lightheadedness, especially when standing up quickly. Remember, while direct-acting vasodilators can be life-saving in acute situations, they require careful dosing and monitoring for safe use. Understanding how these drugs work, their example side effects, and key clinical notes will help you confidently manage patients and tackle NCLEX questions with ease. Let's talk about inotropic drugs, specifically cardiac glycosides. These medications are used to increase the strength of the heart's contractions, making them vital in certain heart conditions. Cardiac glycosides have a positive inotropic action. This means they increase the contractility or strength of each heartbeat, helping the heart pump more effectively. The most well-known cardiac glycoside is digoxin. It's the only agent suited for long-term therapy in heart failure and certain arrhythmias. However, digoxin can cause serious side effects. These include dangerous heart rhythm disturbances, especially if the patient is low on potassium. Other signs of toxicity are nausea, vomiting, fatigue, loss of appetite, and visual disturbances like halos or blurred vision. Digoxin should not be used in patients with AV block or certain abnormal heart rhythms. It's also risky when combined with diuretics, which can lower potassium, or with beta blockers and other inotropes due to additive effects. Let's talk about thrombolytics, also known as clot busters. These medications promote fibrinolysis by converting plasminogen to plasmin, which dissolves clots in the body. Thrombolytics are used in emergencies like acute myocardial infarction, pulmonary embolism, acute ischemic stroke, and deep vein thrombosis. Common examples include alteplase, tenecteplase, and reteplase. The most important side effect is bleeding, especially at puncture sites and wounds. Watch for excessive bruising, petechiae, hematuria, and black or tarry stools. Signs of hidden or occult bleeding include pallor, dizziness, low blood pressure, rapid heart rate, abdominal or lumbar pain, and decreased level of consciousness. Alright, let's kick things off with a super important group, calcium channel blockers, or CCBs for short. Think of calcium as the go-go-go signal for muscles. When calcium enters the muscle cells of your heart and blood vessels, it makes them squeeze and contract. CCBs are like the bouncers at a club, standing at the door and telling some of that calcium, "Sorry, you can't come in right now." By blocking or slowing down the flow of calcium, these drugs help the smooth muscles in your arteries relax. When the arteries relax, they get wider, a process called vasodilation. This makes it easier for blood to flow, which lowers blood pressure. It's like going from a tiny straw to a big garden hose. Now, why do we use these? Hypertension, angina, arrhythmias. First, you have the pines, nifedipine and amlodipine. These mostly work on the blood vessels, making them excellent for lowering blood pressure. Then you have the non-dihydropyridines, verapamil and diltiazem. These guys are double agents. They relax blood vessels and slow down the heart rate by acting on the heart's electrical conduction system. Because they relax blood vessels, they can cause dizziness, headaches, flushing. A big one to watch for is peripheral edema, swelling in the ankles and feet. With verapamil and diltiazem, since they slow the heart, you have to be on high alert for bradycardia and heart block. Before you give any CCB, you absolutely must check the patient's blood pressure and heart rate. A common rule is to hold the dose if the heart rate is below 60 beats per minute or if the systolic blood pressure is less than 90 or 100 millimeters of mercury. And here's a classic NCLEX tip. Teach your patients to avoid grapefruit juice. It can block the enzyme that breaks down many CCBs, leading to dangerously high levels of the drug in the body. Slow position changes are also key to prevent dizziness from orthostatic hypotension. Next up, let's talk about the fast-acting heroes for chest pain, nitrates, with the star of the show being nitroglycerin. Angina happens when the heart muscle isn't getting enough oxygen-rich blood, usually because the coronary arteries are narrowed. Nitrates are powerful vasodilators. They relax and widen blood vessels. Their main trick is dilating the veins, which reduces the amount of blood returning to the heart. For acute angina attacks, the most common form is a sublingual tablet or spray. You place it under the tongue where it dissolves and gets absorbed directly into the bloodstream. For long-term prevention, patients might use a patch, an ointment, or an oral extended-release tablet. For a patient with chest pain, the standard protocol is to give one sublingual tablet every 5 minutes for up to 3 doses. If the pain isn't gone after the first dose, they should call 911 before taking the second. Let's move on another cornerstone of cardiac care, beta blockers. If you see a drug name ending in olol, think beta blocker. These drugs work by blocking the effects of the hormone epinephrine, also known as adrenaline. Adrenaline is your fight or flight hormone. It makes your heart beat faster and harder. Beta blockers essentially tell your heart to just calm down and take a deep breath. By blocking these effects, they decrease the heart rate, reduce the force of the heart's contractions, and lower blood pressure. Cardioselective beta blockers, they primarily target beta-1 receptors found in the heart. Non-selective beta blockers, like propranolol, block both beta-1 receptors in the heart and beta-2 receptors in the lungs. Be extremely cautious about giving a non-selective beta blocker to a patient with asthma or COPD. It could trigger a severe asthma attack. A more subtle but dangerous adverse effect is that they can mask the signs and symptoms of hypoglycemia in patients with diabetes. Just like with calcium channel blockers, you must check the patient's heart rate before giving a beta blocker. Hold that dose and call the provider if the heart rate is below 60 or if the systolic blood pressure is below 90 to 100 millimeters of mercury. You also need to teach your patients that they should never ever stop taking a beta blocker abruptly. The dose must be tapered down slowly over a week or 2 under a doctor's supervision. Suddenly stopping can cause rebound hypertension or a rebound tachycardia, where the heart rate and blood pressure shoot up to dangerous levels. This is all about preventing a sudden surge of adrenaline from overwhelming the newly unprotected heart. Okay team, let's tackle the drugs that fight one of the biggest villains in heart disease, high cholesterol. These are your lipid-lowering agents. The most famous ones are the statins. Names usually end in statin, atorvastatin, simvastatin, rosuvastatin. High levels of bad cholesterol, LDL, which stands for low-density lipoprotein, can cause plaque buildup in the arteries, atherosclerosis, that narrows arteries and leads to heart attacks and strokes. How do they work? Statins act mainly in the liver. They block an enzyme called HMG-CoA reductase. That enzyme helps make cholesterol. Inhibiting it reduces liver cholesterol production. The liver then pulls more LDL from the bloodstream. Net effect, lower LDL levels. Stop the factory, use up the stock. The most common side effects are generally mild. Gastrointestinal upset, headaches. Two major adverse effects to know: hepatotoxicity, liver damage. Because statins work in the liver, they can cause liver injury. That's why liver function tests are monitored before and during therapy. The second is myopathy, muscle pain, tenderness, weakness. Rarely, this can progress to rhabdomyolysis, where muscle breaks down and releases a damaging protein into the blood, which can cause kidney failure. Nursing responsibilities, monitoring and patient education. Teach patients to report unexplained muscle pain, tenderness, weakness immediately. This is not something to ignore. Also report liver signs, yellowing of the skin or eyes, dark urine, severe abdominal pain. Timing tip: some statins like simvastatin work better in the evening. Cholesterol production is highest at night. Encourage medication plus lifestyle changes. Heart-healthy diet, regular exercise. Statins are a cornerstone of primary and secondary prevention of cardiovascular disease, working best as part of a comprehensive approach to heart health. Let's shine the spotlight on another cornerstone of cardiovascular pharmacology: angiotensin-converting enzyme inhibitors, ACE inhibitors, powerful tools for controlling blood pressure and protecting the heart. Hypertension, heart failure, after a heart attack. So, how do they work? They block the enzyme that converts angiotensin I to angiotensin II. Angiotensin II narrows vessels and raises blood pressure. Stopping this conversion lets blood vessels relax and widen. That makes it easier for the heart to pump and lowers blood pressure. You'll recognize them by the pril ending: lisinopril, enalapril, captopril, used for high blood pressure. Also slow progression of chronic kidney disease, especially with diabetes. But they have side effects: persistent dry cough, elevated potassium, hyperkalemia, low blood pressure, hypotension, angioedema, swelling of the face, lips or throat, medical emergency. For NCLEX, remember, lower blood pressure by blocking angiotensin II formation. End in pril. Can cause cough, can cause hyperkalemia, can cause angioedema, especially helpful in heart failure and in diabetic kidney disease. Understanding ACE inhibitors means knowing not just how they work, but how they fit into the bigger picture of cardiovascular care. Now, let's talk about a true cardiac red alert: hypertensive emergencies. Picture this: a patient's blood pressure skyrockets to dangerous levels, often above 180/120. This isn't just high blood pressure anymore. In a hypertensive emergency, those numbers are so high that they start to damage vital organs like the brain, heart, kidneys, eyes. What causes this crisis? Suddenly stopping blood pressure medication, uncontrolled chronic hypertension, kidney disease, certain drugs like stimulants, pregnancy complications such as preeclampsia. Symptoms might include severe headache, vision changes, chest pain, confusion, seizures, all signs that organs are in distress and need immediate help. So what do? The goal is to lower blood pressure quickly but safely to prevent further damage. This is where fast-acting IV medications come into play. Nitroprusside, labetalol, nicardipine, given in a controlled environment, usually the ICU, where nurses and doctors can monitor the patient closely. It's vital not to drop the blood pressure too fast. That can cause more harm than good. Instead, the target is to reduce it gradually, protecting those precious organs. Hypertensive emergencies are a true test of clinical skill and teamwork. Recognizing the signs, knowing the causes, understanding the treatment options can be life-saving. Remember, in these situations, rapid response and careful monitoring can make all the difference. Acute myocardial infarction interventions. When a heart attack strikes, rapid intervention is critical. Thrombolytic therapy can restore blood flow to the heart muscle by dissolving clots, but it must be given within hours of onset. Antiplatelet and anticoagulant medications help prevent new clots from forming. Nitrates relieve coronary artery spasms and improve blood flow. Beta blockers reduce the heart's oxygen demand and lower the risk of death. ACE inhibitors support heart function and recovery. Pain management, often with morphine, is also essential to reduce stress on the heart. While anticoagulants prevent new clots from forming, thrombolytics are used to dissolve existing clots in emergencies. Imagine a blocked pipe. Thrombolytics act like a chemical drain cleaner, breaking up the blockage and restoring flow. How do they work? Thrombolytics activate the body's natural clot-dissolving system, converting plasminogen into plasmin, which then breaks down fibrin, the main component of a clot. This rapid action can be life-saving in situations like acute myocardial infarction, ischemic stroke, massive pulmonary embolism, where every second counts. Common drugs in this class include alteplase, retiplase, tenecteplase, but these medications aren't risk-free. The major side effect is bleeding, sometimes severe or even life-threatening. That's why strict eligibility criteria and careful monitoring are crucial. Nurses must watch for signs of internal bleeding, check vital signs frequently, and know when to stop the infusion. Key points to remember: thrombolytics are for emergencies, work fast to dissolve clots, and require vigilant monitoring for bleeding. Know their indications, mechanisms, and side effects. These details could make all the difference on your NCLEX and in real-life critical care situations. Let's talk about hypertensive emergencies. A hypertensive emergency is when the diastolic blood pressure is greater than 120 millimeters of mercury, with evidence of target organ damage, usually to the kidney, heart, or brain. This is a true medical emergency that requires immediate intervention. Hypertensive emergencies can be caused by primary hypertension or secondary to conditions like eclampsia, head injury, pheochromocytoma, or thyroid crisis. One of the main treatment options is nitroprusside. It has a very short half-life, allowing for rapid blood pressure reduction with intravenous administration. Continuous monitoring is required as the drug is metabolized to cyanide, which can be toxic to the body. Other medications include clonidine, captopril, and furosemide. These are used if blood pressure is elevated but organ damage has not yet occurred.